thought I'd rather than go through lots of subjects with you, I just thought a few thoughts on getting the best patient, the right patients to see me, and hopefully that will save, at least saving the NHS some money. I'm not so sure about saving the private sector money, so that's really not a great idea from my point of view, but certainly NHS wise anyway. So just these are the commonest things that I see in my clinics, and I'm just going to run through and I'll give you a sort of money-saving referral tip on each of those conditions. So obviously carpal tunnel syndrome is far the most common thing I see. Trigger fingers, ganglions, juvenile disease, arthritis, and then the thing at the end, wrist pain, unexplained wrist pain. So carpal tunnel syndrome, I'm sure you all know this, but it's pretty typical in a lot of patients. They have typical night pain, they have reduction in dexterity, the symptoms in the median nerve distribution, and then they start to get daytime symptoms. And the typical patient is a middle-aged female who starts getting woken at night and then eventually starts getting problems during the day. Don't need you to know that, you just take a good history. Okay, but nerve conduction studies, I'm always getting referred patients saying, will you do nerve conduction studies on this patient? Well, the first thing is they cost quite a lot of money, at least in the private sector they're probably at least a couple of £100. If you send them to the NHS, it's £150. If we do them in our clinic, it's about £70. And I would argue that not all these patients require nerve conduction studies. In fact, one would argue that if they've got typical signs and symptoms, why do a test that's only about 95% accurate anyway? So save yourself some money. I don't want nerve conduction studies on patients who are middle-aged, who've got typical carpal tunnel syndrome. Second thing, trigger fingers. Trigger fingers, and I'm sure you've all seen these, you know how to diagnose them, pain around the base of the finger. Triggering maybe, sometimes they don't always trigger, sometimes they just can't flex it properly or they can't extend it properly, it's painful down the finger. This is where the inflammatory problem is at the base of the flexor tendon here. They've always got pain when you press, they often get a click or a clunk. Steroid injection, first line treatment, definitely the best way to treat these patients in the outset. You do need to make sure you get it in the right place because the efficacy of it is pretty good. And maybe that efficacy of 60–75% is a reflection of how accurate we are at sticking it in the right place. Because I think if you get it in the right place, and the patient will say, if you get it in the right place, the patient will say, that's gone right down the finger. So if you inject it in the flexor sheath, they should be able to feel it go right down the finger or the thumb. If they don't feel that, chances are you've probably not got it in the flexor tendon sheath. But if you do get it in, a lot of them will get better, and it's a curative thing. It doesn't matter. Some of them do relapse, but a lot of them don't. You can see if you start redoing it, the injections become far less efficient. You know, the second time round, you're only getting 1 in 4 working. By the time you get to a third injection, you're wasting your time. We know that injecting things into tendons or around tendons, steroids, is a bad thing, you know, repeatedly. So there is no really good indication for doing more than 2 injections. And I would argue, possibly, if you've got it, 1 is probably all you should do if you're sure it's in the right place. Surgery, obviously, is the final outcome if all else fails. Very successful operation, fairly straightforward, obviously fairly expensive. So I would argue that the treatment is initially is maybe non-steroidals, a splint, and give them a bit of time so if you get better. Try an injection, make sure you know how to get it in the right place. You can usually tell from the patient. Surgery, if it's failed or if it's locked up so they can't strain it at all, steroid injections probably don't work in those sort of situations. Ganglions, my least favourite operation as a hand surgeon. Unfortunately, it's not really indicated. About 50% of ganglions will disappear at a year, and probably at 5 years, probably 75% disappeared, and the recurrence rate from surgery is pretty bad. But these wrist ganglions, the ones on the front of the wrist, the volar wrist ganglions, the ones on the back, recurrence rate of 25% or more. Well, that's terrible, isn't it? What an awful lot. And these patients really don't like you. They come along with a lump that doesn't really hurt, although they say it does, and they do an operation, and they don't have a lump, and it hurts. So they're not happy. So basically I would say, unless you really, really twist your arm, or they're really, really painful, don't do it because of these outcomes. Having said that, and a caveat here, is the flexor tendon ganglion. This is the little ones that occur at the base of the finger. They feel like little peas or little bits of bone. These are quite painful, and they do get in the way, and really the only treatment for those is surgery. Aspiration of them doesn't work, and hitting them with the Bible doesn't work either. But for those ones, surgery is good, they don't very rarely to come back, and patients are generally pretty happy with those sort of ganglions. So, don't treat wrist ganglions, do treat flexor tendon ganglions. This is the sort of cost you're talking about. Privately, I'll take it out for 1,500 quid, why not? The NHS costs you 800 quid on the NHS to have one of those done. Dupuytren's disease, that's a far more interesting area that I get sent now. A lot of the patients now, we certainly go for a fasciotomy for a lot of patients with this kind of contracture, where the palm band is in the palm. You can do a very limited procedure, either with a surgical blade or with a needle, just doing a sort of mini-operative release of that. Having said that, once the disease extends down the finger, then that sort of procedure doesn't really work. And the traditional way of dealing with that was fasciectomy. And that's obviously, those of you who've seen any of those, very extensive operation, lots of wound problems they get. They end up with a lot of physiotherapy, splintage, etc. for several weeks. The whole process for the patient is quite labour intensive. I'll introduce you to collagenase. Some of you may have heard of this. This is coming on the market now. This is basically an enzyme that dissolves the collagen that's in the Dupuytren's disease. So this is a specific enzyme that dissolves the type of collagen that's in the Dupuytren's. So that sounds really good. It does have some effects on other things in the finger, most noticeably the flexor tendons and the nerves, although it's not very specific to those. So as long as you keep it reasonably away from those structures, then it won't affect them. So this is the way forward, I think. So this is called Xiapex's latest thing. We have not got a license to use this in the NHS yet, and the reason is because of that. It's £600 to £800 per injection. So that obviously is pretty expensive for something that comes in about 0.2 of a mil. So you don't get much for your money there, do you? But the way this works is you inject the Dupuytren cord on day one, and the patient gets a bit of a reaction. They often get a little bit of tenderness, a little bit of swelling around the injection site, and you bring them back the next day, and you do the most subtle of orthopaedic procedures, and you just give it a good snap. And it seems to work very nicely. It hurts a little bit as you do it, and you can put a bit of local anesthetic in if you want to, but for most patients you can actually snap it out the following day. Depending on how experienced you get with this, maybe up to 50% of patients with Dupuytren's are suitable for this type of intervention. It's not suitable for patients who have previous surgery, and it's probably not indicated for patients with really bad contractures, but it can be done. However, having said that, some of the patients, there is a suggestion that if they've got a fairly significant contracture, they may need more than one injection, which obviously ups the costs quite significantly. So this is sort of costs that you would probably a patient would encounter. Fasciotomy, just simple nick. If they come into hospital, NHS, 800 quid. Ridiculous, that's what they do charge for it. Privately, 1,500, ridiculous. It's a 5-minute operation. Fasciectomy, much more difficult, much more, and £2,000 is a bargain because the patients come back every sort of few days and lots of physio. Collagenase injections starting off at around about 600, maybe a bit more in the private sector. So if you weigh them against fasciectomy, it probably makes sense. If you weigh them against fasciotomy, hard to justify. Okay, osteoarthritis of the thumb. Again, a very common thing, unfortunately, middle-aged females again. Reduction in grip strength, they get pain at the base of the thumb, loss of grip, deformity, pain, reduction in movement. So these are the recommended or suggested treatments for osteoarthritis. So there's pretty limited things I can do for these patients if they've gone through the painkillers and so forth. Splints, very cheap. Nobody ever wears them, do they? They just get in the way. If you inject it blindly, it's a relatively easy, cheap thing to do. We can do it as part of our NHS outpatient clinic. So it's this 150 quid here is the actual cost of a GP for coming to see me in clinic. Privately, they'll charge you a little bit more for that, but it's not terribly effective. It's quite a difficult joint to get into, and the more arthritic it gets, the less likely you are to get into it. If you do it under X-ray, you get better efficacy, so up to 75% will work at least in the short term, but it costs more. But I would sort of stress that surgery is a good option for these patients. It's quite expensive, as you can see, but it works for the vast majority, something like 90%, and it's a permanent solution. Obviously, injection for osteoarthritis is never a permanent solution, so at some point their symptoms will recur. So repeated injections, you start to rack up the costs, and the efficacy is starting to decrease on every injection. So my last little tip for you is on wrist pain. Now, I guess as physios, probably a lot of common physios here, you get quite a lot of patients who come along with wrist pain and you go, what on earth is going on here? I've not really got to the bottom of this. Take a history. Two important things. Is this traumatic? Have they had an injury? And if so, is that recent or is it old? Or has it just sort of crept up on them and then it may have just got a little bit worse when they've done some sort of sporting activity? Whereabouts in the wrist is it? In particular, which side of the wrist is it? Is it ulnar or radial side? So is it this side, little finger side or thumb side? And what makes it worse? That will help you to get to the bottom of some of the problems. Examine the wrist. Again, examine each side of the wrist. Where is that pain? Is it ulnar or radial sided? And there are some stress tests which are in the previous MOG newsletter if you're interested. I wrote an article with my hand therapist about those, about how you stress the wrist and how you assess whether there is or isn't ligament injury. But my top tip is to try and stop seeing so many patients with pointless MR scans of the wrist. Plain MR scanning the wrist is quite cheap now, probably 200, 250 quid, not too expensive, but it's no good for non-acute problems by and large. So it's great for diagnosing fractured scaphoids, fractures of the carpal bones that we don't know, or acute soft tissue injury. So if you've got something acute, it's fine. An MR scan is great. If you've got a chronic problem, it's not so good at all. It doesn't really show the ligaments to the wrist, it doesn't show the triangular fibre cartilage. You need to do an MR arthrogram. Now that is a much more expensive test, 2 or 3 times the amount. But this is an MR arthrogram, and this shows lots of things that you would never see on an MR scan. Most notably, a hole in the triangular fibre cartilage, that's here, the dye is running into the distal radial joint, and a defect in the scapholunate joint as well. The MR arthrogram in a chronic wrist pain is a far better investigation on the assumption you know what you're looking for in the first place. But I see lots of patients who come along with a plain MR scan and they have some sort of wrist pain, and the MR scan says, well, they may or may not have a bit of a triangular fibre cartilage tear or something similar. It's not that useful. We often have to repeat and do a second MR scan. So, my top 6 tips. Save yourself some money, save me some time. Not all carpal tunnel patients need nerve conduction studies. Don't send me ganglions. I don't like doing it. It's a horrible operation. The patients don't really like it, except for flexor tendon ganglions. Don't keep re-injecting trigger fingers, particularly if you know you're in the right place. Xypex, collagenase for Dupotrons, but definitely is going to be the way forward, I think. I'm sure the cost of that will come down. Osteoarthritis of the thumb, don't do repeated injections if you're not sure you're in. X-ray helps enormously get in the right place. And don't forget that surgery is an effective and permanent solution to the problem for them. And the last point, obviously, about MR scanning. Fine, plain MR, acute injuries, but for chronic injuries, it's really not so good. Okay, thank you very much.
Okay.